Okay, great. We're so glad to welcome Dr. Zahed today to give updates on deep brain stimulation. And I've asked her to kind of start with some introductory information just to be sure everybody's on the same page. And I'm sure she'll have an opportunity to take questions as we go along. And if you have any questions on DBS, we'll try to get to those first. And if you have any additional non-DBS questions, I'm sure Dr. Zahed will take those too. And we'll plan to end at it's 2:30 now. We'll plan to end at 3:50, so Dr. Zahed can get to her 4 o'clock patient meeting. So, all right, take it away, Dr. Zahed.
Thank you so much for the introduction, Robin, and thank you for all for joining today and taking the time. I'm really glad to be here today. As Robin mentioned, my name is Hengameh Zahed. I am one of the clinical assistants. We will be talking about updates in deep brain stimulation today. Given that this is quite a broad audience with both the Palo Alto support group and the DBS support groups together, I imagine that we have folks from all kinds of levels of familiarity with deep brain stimulation. Some of you may have never heard of it or very briefly only heard about it. And some of you might be veterans of DBS and have already gone through the process yourself or might be familiar with it in other ways. So I thought as a way of leveling the playing field a little bit, I would give a brief introduction into DBS about the why, who, and when. For those of you who are veterans of DBS, please bear with me as I go through these slides. Hopefully I don't bore you too much. And for the rest of you, hopefully this sets up a little bit of a stage about what we're going to talk about throughout the rest of the hour today together. And then afterwards, I'll give you some recent advances in deep brain stimulation technology that include some of the advances in devices and technology themselves, and then other new directions of research that are interesting. These are definitely not soon, and there are things to keep an eye out in the coming years. So with that, let's talk about why and when to consider deep brain stimulation. So I really want to be clear here and say that DBS is not a cure. It's not for everyone. It has certain risks that need to be considered as someone is going through the process of getting evaluated for deep brain stimulation. And it is not a treatment for all symptoms in Parkinson's disease. That said, for patients who are properly selected, it can really help reduce motor fluctuations. It can, in some patients, reduce medications by even significant amounts, and it can really help improve the quality of life for many patients. So it can be a really important cornerstone of overall Parkinson's care for many patients. When to consider it, the answer is when patients start having some fluctuations and their medications aren't working as well as they were doing before. So this particular slide, let's imagine someone is in the early stages of Parkinson's. They take their medications. These are the blue dots, sort of as the disease advances. They take their medications, they get a benefit, the medication wears off, they take their next dose. But importantly, the symptoms are overall well matched by the medications, and the fluctuations are not so much, such that patients are spending a lot of time, the levels of the medication wearing off too low, or start, having these peaks going into these areas of too much effect, such as dyskinesias. And so patients are kind of nice in this nice little green window of what we call therapeutic window. And then as the disease advances, they start having to take medications more frequently. As you can see, there's more number of blue dots here, for example, in this schematic. And then not only that, but the fluctuations are more significant. So their peaks and valleys in their medications and how well it works for them changes, such that now they start, occasionally going into these periods where they're in the off state. The medication is not working very well for them, despite the higher frequency of the medications. And there are times that sort of also countered by the fact that there are times they're over-medicated, and then spending this disconnect can become even more prominent. So the time when we start considering deep brain stimulation is, generally speaking, in this area where patients are starting to develop fluctuations that are bothersome, but it's not, so advanced where they're really not getting a whole lot of benefit from their medications anymore. The deep brain stimulation itself has three main components. There is the electrode lead that gets implanted into the deep structures in the brain. There's two main areas in the brain that we implant for Parkinson's, and that's the subthalamic nucleus here. It's sort of like in deep area here, or we call it the SDN, and then the globus pallidus interna, or GPI, and that's a little bit more lateral in this structure that in this schematic is kind of here. And these are, again, deep structures in the brain, occurs through contact with these that are placed in these structures. And then you have the extension wire that gets tunneled under the skin, so nothing is exposed. It's all tucked under the skin, and then it gets connected to this implantable pulse generator, or what we call an IPD. This is actually where the brains of this device is. This is really just the pacemaker part of it that gets all of the signal that gets delivered. The electricity gets delivered through into the lead. It's all set in this pulse generator. So here's a video from one of our own neurosurgeons, Dr. Vivek Butch, describing in a little bit of detail about what the procedure is like. And so I'm just going to let it play out for you. Hopefully it will play. It's thinking.
Deep brain stimulation is a minimally invasive procedure. It can be effective at treating conditions such as essential tremor, Parkinson's disease, and epilepsy. The idea is that we use the brain's natural language, which is electricity. And instead of making the brain talk in a particular way, we're disrupting the brain from talking in an abnormal way. The first part of the procedure is where we implant the actual electrodes into a very specific nucleus in the brain. Typically, patients have it done on both sides to treat symptoms on both sides of the body, but it doesn't have to be that way. It can also be one-sided. If it's both sides of the brain that we're treating, then we would make a small incision on both sides of the scalp. It's usually about 2.5 centimeters long, and make an opening in the bone about the size of a dime. And we use a very precise apparatus to gently guide the electrode through the brain tissue and down into that target nucleus. We use microelectrode recording to actually listen to the brain cells. And by listening to the brain cells on the way down, I can actually tell exactly where we are in the brain. And then we can finish up with that first procedure by just taking the electrodes that are now in the brain, and the back end of those electrodes, we just pocket them behind the ear underneath the scalp. And the total procedure takes somewhere around 2.5 to 3 hours. Then we bring them back for the second stage, which can be anywhere from a few days to maybe a few weeks later. And the second stage is where we take the back end of those wires, which we tucked underneath the scalp. We just make a small opening right on top of those wires, and then make an incision in the chest where the stimulator itself will go, which is kind of like a pacemaker, but for the brain. And then we create a pathway underneath the skin to connect from the top of the head to the chest. And that procedure itself takes about 30 minutes and is an outpatient procedure. There's two things.
Okay. So with that, it's important to know that it's not you just turn it on and it, magically starts working. There's this process of programming the deep brain stimulation afterwards, and this process of fine tuning. But with that, DBS can be helpful for some symptoms, including tremor, slowness, stiffness, dyskinesia, those irregular jerking dance-like movements, and dystonia, those abnormal postures that sometimes patients with Parkinson's will have. So here's an example, not one of our patients, but easily available on YouTube if you were to Google on and off with DBS. So here's a patient who has quite prominent tremor, as you can see on the left, before he had his DBS implanted, and then compared to after DBS, where you can see his tremor is much better controlled compared to before DBS. Okay, so with the ground hopefully set as so everyone has a somewhat comparable understanding of what DBS is, let's talk a little bit about recent advances that have occurred with respect to DBS. So do with adjustments to technology or improvements in technology that have really allowed us to better control the programming of DBS and in some cases allow for faster and more optimal programming. So here, what is shown is the fact that in the old systems, essentially this electrode, the part that actually the lead that goes and gets implanted into the brain, it used to have these contacts at various levels, and it was just this ring structure around at each level. And so you would go in and turn, depending on what you wanted to control, you would turn on a level, and you would get this ring-like stimulation around the entire electrode. Now, the brain, sort of in the areas of the brain that we're going, places like the STN or GPI, there are lots of structures going through the brain. These are tight, compact places. And so what, was very frequently encountered was the fact that you wanted to activate an area of the brain, let's call it the sweet spot, this green area in the schematic here. And then adjacent to it would be another structure that would be not involved in the symptom you're trying to improve, like such as tremor, but it would lead to other side effects if you actually activated it, such as the pulling that you might, patients might get, or tingle-like bothers, some sensory symptoms, changes to speech or vision. So let's call that the sour spot. So in the old days, when you activated just a ring around this electrode at this level, you would end up activating both the sweet spot and the sour spot. So patients would end up in a situation where they might get great benefit to their tremor or whatever symptom, the slowness that you're trying to address, but they would also be limited by the side effects that they were encountering by the activation of this sour spot. So one of the recent advances, it's not as recent, but in the last few years, we've had the technology where now at each level, the lead is segmented. So instead of just having one ring around that level, you have these three separate components, and you can turn each one of them on or off, or adjust the amplitude at each one of these segments sort of independently. So this gave us much finer control. So now if you were to activate this ring level, you would again have both the benefit and the side effect, but you can steer this away by turning off this segment, for example, where you're directing most of the activation energy towards the sweet spot and away from the sour spot. So this has allowed us to fine-tune programming of DBS devices in patients who have these segmented leads. And fortunately, this is now available in all of the major DBS devices that patients get implanted with. Another recent advance has been the use of image-guided programming. There's been a lot of work in, before it used to be that you just would get coordinates, maybe you would get some information from intraoperative monitoring about a sense of where you are in space. You could get an X-ray and just grossly have a sense of where these leads might be. But otherwise, it's kind of being in a dark room, trying to say, where are we in space? And imagine you're blinded, you can't see anything, you're just touching the walls and trying to get a sense of where you might be in space. And that's how we used to program. We would, adjust the stimulation at each level until we, got to certain side effects. And by virtue of knowing where those side effects would map to, certain anatomical pathways, we would say, oh, this is where we might be. But it was all sort of through this process of trying to adjust the stimulation and making a guess at where we thought exactly how it was oriented. But some of the newer technology has now allowed us to actually try to use that information that we have from high resolution structural imaging, like the MRI, and map it onto where the leads are, and try to get an estimate of where, like a description of where it might be. So on the patient programmer, for example, here with the Boston devices, you can see this area, you can see the electrode, and then it shows you can turn different areas that you really want to stay away from or really want to target, and you can try to use that to get a quicker sense of where you might be. These are not perfect. You still have to fine tune them. You still have to use your clinical experience to know where you're targeting and how to adjust the stimulation parameters. But this has allowed, there's many studies that have shown that actually using approaches such as image-guided programming can shorten the amount of time to get to do, through that optimization process. Another advance has been using another technology that's called sensing-guided programming, and this is now available in the newer Medtronic devices. I will talk a lot more about these brain signals in just a minute as we're talking in the next segment. But electrodes in the brain, and normally these electrodes can, with information from the pulse generator, they can stimulate the lead. But these newer leads can not only generate this electrical signal and stimulate the brain, but they can also listen to the sound of that activity of the brain. And in the video you saw that Dr. Butch was talking about the fact that by listening to the activity of the brain cells as he's going through, he can tell where he is, because different cells in the brain in different locations have different properties of firing. And so we can also use this to try to say, okay, well, this is where we think, the area of importance is. And using this, again, you can try to optimize or speed up the process of detecting, choosing which one of the electrodes you want to activate and how. There's a lot of really, like this whole section could be a whole talk of its own, but for the sake of time, I'll sort of brush through it. Another really interesting and exciting area of research is exploring new electrode locations. So locations that are actually currently approved for Parkinson's disease stimulation are the subthalamic nucleus, the SDN, and the globus pallidus interna, or the GPI. Those can be really helpful for things like tremor, slowness, and stiffness, but we don't actually know that certain symptoms can actually worsen with DBS or may not be improved at all. And sometimes those are the symptoms that patients care about the most. That includes walking, freezing of gait, and cognition. And all of those can potentially get worse with the traditional targets of DBS. Now, some of the newer approaches are trying to look at, can we use other areas in the brain? And I would say this is still very preliminary, but one of the areas that is still being investigated is what's called the cuneiform nucleus. That's actually a much deeper structure. So here, for example, as you can see, the SDN and the GPI sit here. The cuneiform nucleus is down, even further deep into the brain, in the midbrain. And it's been closely associated with another structure called the PPN, or the pedunculopontine nucleus. There were some studies done in the PPN nucleus with some mixed results, but now folks are starting to think about whether or not the cuneiform nucleus might actually get better results where the PPN nucleus previously failed, specifically with respect to using DBS as a way of improving walking and freezing of gait problems. This study currently is recruiting at University of Miami. It's not being done here, but it is an area to keep an eye out for. Another area that is recruiting at Stanford is the nucleus basalis of Minard, or NBM. And this one sits kind of just below the globus pallidus interna. And it's thought to be involved in at Stanford, the lab of Dr. Helen Bronte-Stewart is trying to look at whether direct stimulation into the NBM can actually be helpful for cognition in Parkinson's disease. And it's also being studied in other conditions like Alzheimer's disease as well. But again, these are pretty preliminary early stage studies, but things that are potentially very exciting for the future. I'm going to spend the majority of the rest of the time talking about another area that has been quite interesting, called adaptive or closed loop DBS. There's been a lot of hype about it. You might have been coming to this support group for some time, and if you have been to one of these in the past, I believe Dr. Bronte-Stewart gave kind of a whole talk on the adaptive DBS, or the ADAPT-PD trial through Medtronic. So some of this, again, might be familiar to some of you. Hopefully it will be a refresher, and for those of you who have not heard it before, it'll be new. So currently the way the DBS works is that it's an open loop brain pacemaker. What that means is that we as clinicians program this, the pacemaker, it sits in the chest, and that delivers a stimulation, and that stimulation controls the motor symptoms a patient has. It is delivering a constant stimulation for the most part, and that's set by clinician in the clinic. Patients can sometimes, click 1 or 2 points up or down, but for the most part, it's just delivering a constant stimulation. And until someone else is doing something to it, that's just a constant stimulation that it's going to deliver. And obviously, with such a structure, it lacks the dynamic response to changing clinical states that patients might very frequently experience, even after DBS and medications. In a perfect world, we would be able to, feed it with these other signals. So, for example, if you could detect peripheral signals from, either the tremor in the arm or the slow movements, the bradykinesia, and you could feed, provide a feedback loop device is giving based on that. And then another thing might be actually using the brain signals themselves to inform the stimulation that this delivers. This part would be very similar to cardiac pacemakers that can detect the electrical activity of the heart and adjust the frequency of their signals based on that signal. And in this case, we would be using brain signals, except the brain signals are much smaller than heart signals, and they're much more technically challenging to work with. There are some barriers to being able to use just peripheral signals. I mean, one can envision, well, it should be easy, just throw, a device that can track tremor, like a peripheral wearable, and then just connect it. But there's a lot of logistical and ethical considerations that need to be taken into account. And it's not as simple. But the beauty of using the brain signals is that you can have all of it contained in a single device where that electrode can sense as well as stimulate based on what it's sensing in real time. So let's talk briefly about sensing brain signals. And the important signal that we're detecting is what's called a local field potential. So imagine, here, let me X out of this if I can. Oh, no. Sorry, this is get covered a little bit. But so essentially you have this electrode, you can sit on the brain, and that would be called an EEG or electroencephalography. If you've ever had, one of those things where they detect seizures, they're putting these sticky electrodes on the top of your scalp and detecting signals. We're not talking about that. We're talking about the signals that are, implanted deep into the brain themselves. It's kind of like dropping a microphone into a big stadium, and you're not hearing what each individual person is saying in that big stadium, but you're kind of detecting, the uproar activity of folks in the stadium. So in that same way, you're kind of listening to the average activity of a population of neurons in an area. And if you do that, you just get a bunch of squiggly lines, which are really hard to interpret and, make sense out of. But with this, you essentially use the same tool as signal processing. So you're taking, a squiggly line like this that has, it's changing over time. And one way of looking at it is to say, okay, can we break this down into a summation of various frequencies or frequency waves, mixed together in certain, together to make up this signal. So this is called a Fourier transform. And you're essentially saying, okay, well, if I add the slower wave to this very faster wave, and then on top of it, maybe add a little bit of this really fast, maybe I can generate this. In human brain signals, we tend to lump these up into these fields or these band passes. So beta signals would be things that are in the 12 to 30 hertz range. Alpha signals are things that are in the 8 to 12 hertz range. Theta signals are pretty slow. They're in the 4 to 8 hertz range, and delta signals are really slow. They're the 1 to 4 hertz range. So if you take a signal like this, apply this type of mathematic to it, or signal processing to it, you can generate these curves that are called the power spectral densities, or PSDs, where sort of and the bottom is a frequency, and on the top is sort of like the proportion of the signal that is contributing to the overall signal. And so this is, an example of, various subjects, and you can see that this can look different in each one of them. This one has a larger proportion of frequencies in this, lower frequency, and this one is really missing this like higher frequency, for example. So you can use this to try to make sense of the data. So some of the early work seemed to suggest that in Parkinson's disease, oscillations, think of it here as a peak would be you're listening to kind of all oscillate at similar frequencies such that they're drowning out, they're kind of increasing this peak of frequency together. So some of the early work seemed to suggest that maybe some of these peaks in different frequency bands would correlate with various symptoms. So the early thought was that this beta band correlated with bradykinesia and was a really important marker of Parkinson's disease. And then some others thought that maybe this, the slower oscillations, the delta range oscillations corresponded with dystonia, and these really faster 60 hertz oscillations might correlate with dyskinesia. The beta band has really become an important driver of, signals that we really care about. And that is because STN, so again, much of this work was done in this as well, but in the STN, as you ramp up DBS, you can drown out this beta signal. So here is saying percentage of DBS intensity, starting from black being like the DBS is not on yet at all, to 100 maximum, the green being the 100 maximum voltage that you're setting. And you can see that there's this dose response. So as DBS is getting cranked up and addressing the symptoms, this beta peak kind of gets smaller. So this is correlation, obviously. This part of it is not causation, but you can see that the beta peak can fluctuate with something that dampens symptoms of bradykinesia. And beta power also responds to the onset and offset of medication. So when patients are taking, this is a beta power here, the beta power is high, meaning the relative abundance of that frequency is higher. And then a patient takes their medication, and then 30 to 45 minutes later, levodopa starts kicking in. And as it kicks in, you can see that the beta band goes down. And then as it starts to wear off, the band comes back up again. And so the idea is, can you use, instead of just doing a continuous DBS where it's just not responding to the medications, can you use this beta band as a marker of knowing what the medication is doing, and as a result, adapting the DBS? So the times where the medication hasn't kicked in yet, the beta power is higher, let's give more stimulation. But then as a medication kicks in and it's doing a fine job on its own of treating the symptoms, maybe ramp down the stimulation because the patient won't need it as much, and overstimulating might cause side effects, and then sort of a cycle continues. So that's generally the idea behind this. Now, the nitty-gritty of okay, let's say you sense this data, how would you use it? If you had this signal, how would you use it to adapt the deep brain stimulation program with? And so there are two different ways of doing adaptation. There's what's called a dual threshold. This is where you're defining an upper limit and a lower limit. And you're saying if the beta falls below this lower limit, reduce stimulation, because it means the beta suppress the medication is doing what it's doing. And then if it's above this limit, so the beta is, there's too more of it, suggesting that the medication is low or symptoms are worse, let's crank up the stimulation. And then if it's in between, don't do anything, because that seems like we're in a pretty good spot. So we can, this is called what's called a dual threshold. And the idea of it is really just to help with these longer fluctuations that correlate with the timing of medications. And then there's what's called a single threshold, which generally is sort of faster time scales. And it's saying anytime we have this bar, this level of beta that we think is, acceptable, anytime above it, adjust, or anytime below it, adjust, and so respond in real time. And the idea behind this was, the thinking that sometimes those beta bursts, so a lot of a short period where a lot of the neurons in that population are kind of all oscillating together at that beta range. There's some data suggesting that the duration of that beta burst frequency itself might be problematic and contributing to symptoms. So the idea with a single threshold is to try to, shut it down so that those introduce this noise so that the cells in that area are no longer oscillating together at that frequency. So this really brought the Medtronic ADAPT-PD trial. And this was it was the adaptive DBS algorithm for personalized therapy in Parkinson's disease. The selected patients were those who already had DBS systems implanted into either the GPI or STN, so it could be either, and they had to have a Medtronic device. When they were enrolled, there was this phase where they were monitored in their CDBS, so their constant DBS setting, and this is to establish a 30-day baseline. And then they went into the adaptive DBS setup and adjustment phase. This was a period where we tweaked both the dual threshold modes as well as single threshold modes, and tried to set it up and try to arrive at ideal settings for either of those adaptation algorithms. And then once they completed this phase, then they were randomized into, assuming the two rows were acceptable, they were randomized to either start the ADBS dual threshold first and then switch to the single threshold, or vice versa, dual threshold phase. For the patients who couldn't tolerate one of them, they just sort of were in that whichever adaptive DBS phase that they could tolerate. And they were followed up to about roughly 10 months. And at the end of the study, they could choose to decide whether they wanted to stay in the adaptive DBS or if they wanted to go back to their controlled or their CDBS. Important to note that this study was not designed to compare head-to-head the performance of the adaptive DBS versus the controlled DBS, except that the patients at the end could decide what they wanted to do, whether they wanted to stay on this regimen or not, but that was not a primary outcome of the study. The study altogether enrolled 85 subjects in 10 sites in 4 countries. 68 of them were in the primary cohort. They are in the group that had that ring mode as part of their setup. They did not have segmented leads. And then 17 of them were in the directional cohort, meaning they had those segmented leads, but they were a smaller group since there are fewer patients that have the segmented leads so far. The exciting news, and the other thing that I was going to say is that this was a non-inferiority study, which means that it wasn't designed to prove that ADBS is better than a CDBS, again, because it wasn't a direct head-to-head comparison. But the idea was to establish that it's not, at least not inferior to what chronic DBS or CDBS can do. The good news is that this was completed with encouraging results, and it's currently under review by the FDA. I don't have the exact timeline of whether or if it gets approved or exactly where it's at, but we're hoping to hear about this soon. So with that, I thought I would segue a little bit into something that's been in the news lately, and the timing of this update worked out quite well with respect to when this article came out. So recently in the New York Times, there was a splashy article titled "A Personalized Brain Pacemaker for Parkinson's." I know that it was seen widely because we had multiple patients reach out to us and sort of ask about it. And I think it's a really important and a cool study. So I thought I would use today's time to talk a little bit about this study. This was not done out of Stanford, but it's done by close colleagues over at UCSF. So the study design was that it was blinded, randomized, crossover, pilot trial, meaning it's really just done to prove feasibility, like, can we do this? And it had very few patients in it, only 4 male patients who had DBS, 4 motor fluctuations, but they had persistent fluctuations even on their optimized continuous DBS. So these folks had already gone through 7 to DBS with the best, movement disorder neurologists that they had access to. And despite that, they were still having residual symptoms that were bothersome to them, even after adjustments to their medications and DBS. Importantly for this study, and this is not something that's done in routine clinical practice currently, it's not approved clinically, it's a research study, is that the patients had DBS implanted not into the SDN lead, but also they had this paddle over their sensory motor cortex. So that means that there is this electrode that sits down here, and then there's this other strip of electrodes that sits on the surface of the brain over these areas of the cortex that are part of the motor cortex. And both of these are connected to the same pulse generator that sits in the chest. Here's a schematic of where the electrodes for the 4 patients ended up. This orange structure is the SDN. And then down here is a schematic of where the strip on the core and the surface of the cortex is for each of the patients, the different colors being each of the patients, like yellow, green, red, and blue. And so you can see they're all pretty, close to each other exactly on where the leads are. What was unique about this study is that, unlike the ADAPT trial, where it was predetermined that the sensing signal or the adapting signal was going to be the beta band power, because that's what had been studied the most before, in this study, they decided not to pre-select the frequency band that they were going to use for adaptation of the DBS signal. And here they actually did a comparison head-to-head between the adaptive DBS and the CDBS condition for the patients after they had essentially fine-tuned the ADBS and the CDBS. So the patients, as I said, they were all male. They were mostly in the 50s and 60s. One patient was 47 years old. The important thing here is that the most bothersome symptom was actually different in the 4 different patients. While 3 of them, bradykinesia or slowed movements, was the most bothersome residual symptom. One patient, patient 2, his most bothersome symptom was off medication dystonia. So in his off state, he would have those abnormal postures that were bothersome to him. They also tried to define this, what they called an opposite symptom. So knowing that as you try to adjust ADBS, if you were to overshoot, you were likely to cause some side effect. They tried to decide what that would be. Bradykinesia for these 3 patients was that they were worried about the risk of dyskinesia in them. Those are those twitching, jerking-like movements of the body. But in the patient who had off-medication dystonia, they were worried that if they overshot it, it would cause dysarthria, so slurred speech or speech difficulties for this particular patient. Some of them had residual symptoms on only one side of the body. So patient 1 and patient 4 only had residual symptoms on the right side of the body, but patients 2 and 3 had residual symptoms that affected both sides of the body. So they sort of treated each hemisphere independently. The process was that they would recruit the patients, do the surgery, have a 1 month before you activate the DBS. And then they would do the normal clinical practices, which is that you do over 7 to 31 months of clinical practice as best as you can. You can get this optimization. And then the ones who still had difficulty or fluctuations at the end of this would get enrolled into this. And then they used 1 to 3 months of looking at identifying biomarkers that would correlate with their symptoms during active stimulation. And for the first phase of it, they would bring patients into the clinic. They would streamline or they would stream the brain recordings during certain standardized evaluations. And then they would go send them home and try to continue to collect data during this phase of trying to identify the biomarker. Then once they established clearly what biomarker they were going to use for adaptive stimulation, then they would develop the algorithm. And for this phase of it, it was a combination of using machine learning and AI and standard clinical practice and human intervention of trying to identify and optimize and fine tune these algorithms. And again, they looked at these algorithms and defined them both in clinic and then afterwards sending patients home. This was done with a device that's actually not approved for clinical practice. It's the Medtronic RC+S as opposed to the Percept device, which is clinically implanted. So this is a purely research device, but it allowed them to do these recording of signals at home as well. And then once they felt like they were happy with this algorithm fine-tuning, and again, this takes somewhere between 1 to 6 months, they were then randomizing patients into random chunks of somewhere between 2 to 7 days of either a DBS or a CDBS in a randomization pattern where the pattern of how long they spent in each was randomized so that it wasn't setting them up for any type of bias. And then during this 2 to 3 months, after gathering data 1 month in each condition, then at the end of it, they compared the primary outcome measures, which is what they cared about. So in order to identify the neural signals for adaptation, acceptable upper and lower limits of stimulation. So the neurologist came in and said, well, you can't really, regardless of what the DBS wants to do, it really shouldn't drop below this level, and it really shouldn't go above this level. So a human being, a clinician sort of set the limits of what the DBS could fluctuate in between. And then in the clinic monitoring, they use standard clinical motor tests like, wrist flexion extension, or the MDSU PDRS, which is the scoring system we use to clinically evaluate patients. And at home, they send the patients with a wearable technology called a PKG watch that gets worn on the wrist. And so with this, they were able to monitor patients in whom their residual symptoms were evident in an upper extremity limb. So if it was tremor, dyskinesia, dystonia, as long as that symptom could be picked up by the PKG watch, they had another independent way of verifying the things that they were, the report from the patients. They used a variety of, or a combination of integrated non-parametric statistics and machine learning, as I said, to identify these individualized neural biomarkers for each patient. So interestingly, what they found in this sort of, data-driven way, instead of sort of saying where to go and look, they let the data tell them where there might be differences, is that they found that what they call stimulation entrained gamma state in patients. So what they found was that there is this gamma peak. So gamma is those faster frequencies, somewhere around 65 hertz or so, about half the stimulation rate, because most patients get stimulation at 130 hertz frequency. That signal seemed to be in the medication on state, the gamma was high, and the medication off state gamma was low. And they identified this signal both in the STN, so that deep brain structure, as well as in the motor cortex, though it wasn't both in each patient. In some patients, STN gamma oscillation was much more clear, and in other patients, the cortex gamma oscillation was much more clear. And importantly, they showed that this didn't seem to correlate purely with dyskinesia. There were patients who never actually had dyskinesia, even though the old studies seem to suggest that maybe this gamma band is a marker of dyskinesia. In this particular study, it did not seem to correlate with dyskinesia, but rather medication on and off states. So this is a representation of two different patients. In this particular patient, patient 2 is left hemisphere. STN had a pretty robust gamma peak. And in this other patient, patient 1, the motor cortex, where there was this robust gamma peak. And interestingly, this beta range, so the slower frequency, what was used in the ADAPT trial, was different, between the on and off medication state. But in context where stimulation is happening all the time, this difference seemed to be much smaller compared to the difference that they were detecting in the gamma range. This part of it is actually really cool. So this is where they're streaming the signals from patients in real time. It's a little bit hard to look at, so let me just orient you to it. So this bar is a frequency. So this is a frequency of 0. This is the higher frequency of 80. So gamma would be somewhere around this region. Beta would be somewhere around this region. And then this is time. And then the color coding is the power at each frequency. So the higher the power of the frequency, the warmer the color is, and the less the power in the particular frequency, the cooler color it will have. So what they showed here for this particular patient, and then the time of when they administered the medication is in this red dashed line. That's the time when the patient took their medication, and how long it took until the medication kicked in. And then the black lines are sort of when the most bothersome symptoms start until when they wear off. So in this particular patient, they had this 65 hertz signal that was present, sort of probably when their medication was still in. And then their symptom kicks in, and you can see that pretty nicely corresponds with when this gamma peak is starting to disappear. It hasn't kicked in yet, and then it kicks in, and the gamma peak comes back. And shortly after is when the patient says their symptom is gone. And the same thing happens repeatedly during the course of that day. So showing that really this when the patient was saying is their bothersome symptom of dystonia in this particular case corresponds to where this gamma peak seems to be gone. So you can kind of use this gamma peak as a marker of saying, oh, the medication must be wearing off. Let's do something, adapt the stimulation to try to address this symptom. As I mentioned, the peak was not present in both the SDN and the motor cortex in all patients. And as a result, the final control signal that was used in the DBS adaptation actually was different between the different patients. So patient 1, the anterior cortical montage, meaning the more anterior part of the paddle that sat on the motor cortex, SDN there was most prominent, and that's what they ended up using. In patient 2, both hemispheres SDN had the strongest signal. In patient 3, it was actually the posterior cortical montage, so a little further behind compared to patient 1. And patient 4 was in the same place as the first patient, which is that anterior cortical montage. So this would not be possible in all patients, even if we could get that SDN gamma, because patients don't get implanted with a cortical paddle in routine clinical use. So that's an important caveat to know. But nonetheless, it's really interesting that they have the signal, and it is different between the different patients. Whether that has to do with exactly where the leads are sitting in each patient, because we know as much as we try to really target these to ideal locations, there's always a slight fluctuations in where the lead might end up. So does this reflect the perfect placements of the leads? Hard to know. Nonetheless, so what they actually looked at was comparing 3 separate primary outcomes. And primary outcome is just the measures that they ahead of time said we really care about. So the first one was to look at ADBS effect, or say adaptive DBS effect, on time in a day spent with the most bothersome symptom. So what they saw is that this is patient 1, blue being their control DBS and orange being their adaptive DBS. And the percentage of time that they were awake but with bothersome symptom significantly reduced in the adaptive DBS compared to the controlled DBS. The same for patient 2, patient 3, and patient 4, even though, as you recall, the patient 2 had a different symptom. It was dystonia for him compared to bradykinesia or slowness for the other 3 patients. They showed that the ADBS, the improvement did not come at the cost of worsening the opposite symptom, so the symptom they were worried about if they were to overshoot it. And in most of these patients, it was dyskinesia. For patient 2 was dysarthria, that's slurred speech. And they showed that there was no significant difference between CDBS and ADBS with respect to that bothersome symptom. And they actually also had patients mark the quality of their life. And in this particular set of questions, the patients who had ADBS reported improved quality of life compared to the patients when they were in their CDBS. These are not huge changes, but they were clinically significant and meaningful to the patients. Enough so that they actually were tracking patients to see whether they were able to tell, even though the patients and the clinicians rating them were blinded to what phase the patients were in, but they were having patients track what they thought they were in, whether they thought they were in controlled DBS or in adaptive DBS. And in the vast majority of time, patients could predict, and it had, in one patient initially, it was related to some tingling that then improved once they adjusted the ramp rate of DBS. And while none of them could identify a particular signal that was telling them that they were in ADBS or CDBS, they could tell, and they were assuming that that has to do with the fact that their symptom control was overall better. And so as a result, they were predicting when they thought they were in the adaptive DBS algorithm. Oh. Okay, and the other cool part is while the patients could tell, and so you could say maybe that's just biasing them, so maybe they're just thinking that it should be doing better. They use that wearable technology, the PKG watch, to look to see whether there was an impact. And so for the patients in whom they had a symptom that you could track with a PKG watch, they could show that actually ADBS resulted in less beat bradykinesia fluctuations in all the patients compared to the CDBS, and tracked by the PKG watch, got better in 2 of the patients, and in the other 2 patients, it was just not statistically significantly different. So, here it's a nice validation because the PKG watch really shouldn't be, having bias of any kind. It should just be detecting a symptom, regardless of what the patient might think. So it's giving an objective measure. Even that objective measure seemed to match what the patients were reporting through their questionnaires. They looked at the data in a really cool way, actually. So here it's a little bit of a busy slide, but they were caring not just about the bradykinesia versus dyskinesia or sort of whatever the opposite symptom was, but these symptoms that are generally important to many patients. So they looked at bradykinesia, dystonia, tremor, dyskinesia, dysarthria, and gait problems. And each of the farther you go out, the higher percentage of time spent with that symptom. So this is patient one. Patient one, when the braid and the blue is the CDBS and orange is the ADBS. So this patient, bradykinesia was a big problem for them, and they could show that they reduced the amount of time that they were spent with bradykinesia. Their dysarthria didn't change, their dyskinesia didn't change, their tremor didn't change. Maybe there was a slight difference, improvement actually in their gait. For patient 2, dystonia was one of their big symptoms, and they showed that you can actually reduce the amount of time with this adaptive DBS stimulation where they spent with dystonia, but significantly also that affected their gait, presumably because their dystonia potentially affected their limb as well. And limb dystonia can affect walking. And so showing that their dyskinesia, and without worsening dysarthria or dyskinesia or tremor, this patient, again, bradykinesia, in all the cases, essentially they showed that ADBS was getting patients closer to this area where they're spending less time with any of these symptoms. So it's not like you're trading off control of your most bothersome symptom for some other side effect. So in summary, I hopefully tried to show you that in select patients, DBS can be a really important part of their overall PD management, but it's not a cure and it's not for everyone. So if you have questions about it, I'm happy to answer, but I really strongly encourage you to speak to your clinician and find out more whether this is something that could potentially help you. Advances in technology have really led to improvements in programming of the DBS devices. On the one hand, DBS devices have gotten more and more complex. Right before, you used to have only 4 levels. You either turned it on or off. Now we have a much larger degree of freedom in programming. You have all these, segments, and you can independently apply stimulation or frequent amplitude to each of the segments. So the complexity of programming has vastly increased, but to some degree that has been countered by the fact that we now have new modes of trying to information, such as image guidance and sensing guidance to try to help us program, to mitigate some of the fact that, the increased degrees of freedom of programming just make it harder to program. But some of these recent advances have been really helpful. And then there are new targets for DBS lead implantation that are being looked at to try to treat some of the really challenging symptoms in PD that are currently not being targeted by DBS, such as cognition and gait, though these are still pretty early in their development. And then adaptive DBS is a really exciting emerging area of research. That said, it remains really complex and will undoubtedly evolve in the coming years. In the end, probably we're just scratching the surface of what adaptive DBS might be able to do, but the next few years should be really exciting. That is the end of my talk. I would love to hear if there are any questions. Hopefully I haven't lost most of you. But yeah, are there any other questions already coming in or not?
Yeah, okay, sounds good. That was a real tour de force, Dr. Zahed. Thank you very much for that. It was very interesting. I read that New York Times article, but hardly understood any of it. So I appreciate your going through that research. And I'm sure you've gotten lots of questions from patients in the clinic about that, just as you said. So we have a few questions coming in, and if anybody has additional questions, please put them into either the chat or the Q&A box. So I'll start with a few. You mentioned the near the beginning about image-guided programming and sensing-guided programming. Is this programming that the patient themselves can do, or is it still required that the neurologist has to do the programming?
Great question. Yeah, these are things that still the neurologist has to do the programming. The devices do not allow like on your patient programmer, you're not going to see the sensing mode, and patients don't have that capability. Whether we can ever get the systems simple enough where we can unleash it to patients, I'm not sure. But at this point in time, these are really tools that help your clinicians program a little bit easier and faster. There are a few papers that have shown that the time to optimization can be significantly shortened with using these strategies, and that they converge. So if you blinded a clinician and told them to program and then use these modalities of image guidance or sensing guidance, oftentimes they kind of come up with similar types of programs, but the time that it takes to get there is faster.
Okay, interesting. You mentioned that there was early research going on in two particular target areas, one for walking and freezing of gait, and the other one for cognition. Could you say a little bit more about those? So a couple of questions came to mind was, um, I know a lot of people currently do not qualify for DBS because they already have dementia or cognition symptoms. Does that mean that those people, if this research pans out, does that mean that those people could potentially receive DBS and it wouldn't further degrade cognition? Or what does that target area mean?
Yeah, so that is the hope, but that's a big if. So in the trial that looks at the nuclear basalis of Maynard, the NBM nucleus, it's done at Stanford by Dr. Helen Bronte Stewart. So in that study, patients with dementia are still not eligible for the trial. And the patients who are eligible for it are those who we think qualify for DBS, which means that they don't have dementia and their cognition is not so bad that that we have significant concern about their eligibility for DBS. But testing has identified some areas of concern on their neuropsychiatric testing. So we think they're at a higher risk of developing cognitive impairment or potentially in the future progressing to dementia. And so the goal of this study will be to say, if you implant both in DBS and in MBM, so dual target, can you improve their cognition in those patients who are at a higher risk? So that's several steps removed
Hmm.
from getting to the point where you say, oh, yes, patients with dementia, we can implant this in. But
Mhm.
if, say, this study was completed and it was encouraging, then you can gradually sort of, broaden the population of patients you can study to say, can it actually help in those patients who already have significant cognitive impairment? The jury is out. These studies are in early stages, so don't get too excited yet, but they are, it's really important that it's being done and, hopeful that they can be helpful. So if you have
Okay.
dementia, don't go asking your doctor, like, can I sign up for this trial? Because, at this point in time, it's not recruiting yet. But if you are a little worried on the fence and you're interested in pursuing research, this might be a really interesting study. And you can reach out to Stanford, to your clinician, and get connected with Dr. Bronte Stewart to find out if you might be a candidate for the study.
Okay, and similarly, the other study that was for you identified a target for walking and freezing of gait, that would be primarily for people who have freezing of gait, could potentially, if the research pans out, potentially benefit from DBS at using that target.
Correct. Yeah. So the study that's looking at cuneiform nucleus is really looking at patients who, again, would qualify for DBS, but they have issues with their gait that we think, when we counsel patients, for example, we say, let's really focus on the symptoms that are really important to you. and functionally limiting. And then we can have a realistic discussion about which of your symptoms might get better, which of your symptoms might not get better, which of your symptoms might get worse. And oftentimes when we counsel patients, we say effects on walking is a bit more nuanced and guarded. And walking is one of those things. Sometimes it can, for example, as you saw in the adaptive DBS, the patient whose walking was impacted by their dystonia, their walking got better with their DBS and the adaptive DBS. But patients who are having freezing of gait that's not responsive to medications, generally we think of those patients as ones who, at least with respect to their walking, won't benefit from DBS. And if anything, DBS can make that worse for them. But if the cuneiform nucleus were to be shown to be effective, then maybe that would open it up for patients who were having freezing of the gait as part of their significant symptoms. So again, just saying that these are early in the stage, but hopeful areas that we're all going to be watching carefully to see what comes of them.
Yeah, it's great to know about research that's happening, even if it's, early stages, and we're just in the hopeful stage. We're not, we're not any further along than that. It's great to know that
These
things
studies,
are
they're bold. It's great because they're studying things that are pretty far removed from what is standard of practice these days. And studies like this, require patients who are brave and who are willing to try. So, hearing about these studies and, to the extent that we can find patients to participate in them and evaluate them and evaluate their merits, I think we will all be better off.
Okay. A few audience questions. What is the process for evaluating DBS candidates at Stanford?
Yeah, so it's pretty standardized around the country. So the way we do it is, when you're at the phase where you think you might be benefiting from DBS, you bring it up to your clinician says, yeah, let's, consider it. So first there is an evaluation with the movement disorders neurologist establishing the diagnosis, making sure we're dealing with what's, typical Parkinson's as opposed to those, sister-like conditions, the atypical Parkinsonian conditions, because we don't think patients with atypical Parkinsonism benefit as much from DBS to the same way. So first establishing that this is a regular Parkinson's disease, and then establishing what are the symptoms that are bothersome to the patients, really doing that detailed evaluation of what's bothering you, what's getting in the way of life, what are you hoping out of your DBS. And with that, along with that, establishing levodopa responsiveness, because we know levodopa predicts the response to DBS. So, oftentimes for most patients, for most symptoms, DBS can't really do better than the medications alone, but it can help smooth out those fluctuations that patients experience on medications. The exception being tremor is the only symptom in which DBS might actually do better than levodopa alone. But so what that looks like is we tell the patients to come into clinic without their medications. They will be asked to hold off their medication for a period of time. We give them sort of a standardized clinical assessment. And then we ask them to take the dose of their medication either in the clinic or right before coming to the clinic on another day, and doing that same standardized assessment, and then comparing their scores in the on and off state to see how much benefit and improvements there is in their symptoms. And patients have to have at least a 30% improvement in their symptoms to meet the bar, oftentimes for insurance. If the only symptom is really tremor, sometimes we are able to argue that even if you're not meeting the 30% threshold, it's because the vast majority of the score is coming from tremor that might be refractory to medications alone. But for everyone else, we really want that 30% or higher improvement in their symptoms. And then oftentimes we do, because I mentioned that cognition can sometimes get worse, we do a neuropsychiatric testing, so a battery of tests of cognition, memory, thinking. And then once we have all that data, we have a multidisciplinary team of neurosurgeons, neuropsychologists, movement disorder neurologists, and we present the case and discuss as a team whether we think that patient is a good candidate or not.
Okay. How early in the Parkinson's cycle is someone eligible for DBS?
Great question. This is a little bit of an evolving field. We used to say we really want someone to have at least 5 years of symptoms before we consider. The main reason was that sometimes in that early stage of early, like in the first couple of years, we can't always distinguish patients who have regular Parkinson's from those who have atypical Parkinson's. And so if you were to do DBS too early and you accidentally later realize that your patient actually had one of those atypical Parkinson's conditions, and you haven't really served them well. So oftentimes we say we kind of want to wait at least 4 to 5 years. Now there are some studies suggesting that maybe doing DBS earlier is better, and we're trying to refine what that process would look like. So sometimes for patients who have younger age of onset, where this, very clearly looks like regular Parkinson's. They have, they're in the prime of their career. They don't have 5 years to wait and wait for medications to, to help them. Sometimes we, move that process forward faster. But when it comes to sooner than 4 to 5 years, it's really a case-by-case basis.
Okay. If someone asks, when can we expect this to get approved by the FDA? And I'm
The
not,
ADBS,
yeah, I'm
ADAPT
gonna
trial.
yeah, yeah.
Anyone's guess. I've been hearing since March that it's any day. And here we are in September. So I can't say that I can speak in any way for the FDA. And I'm not privy to oftentimes you go to the FDA has questions, they have concerns, you have to respond to and I can't say that I'm privy to any of that back and forth. So waiting with all of you.
Yeah.
Hopefully.
And with respect to that UCSF study that was mentioned in the New York Times, you mentioned that there were only 4 patients involved, a very small number. So do you envision that that same sort of a study would need to be done in much larger people to be able to have any conclusive results?
Yes, absolutely. And, I think that's why I highlighted in the beginning that this was a pilot feasibility, right? So the amount of work that that study took, even though it was only 4 patients, sort of reading through the logistics of it, it's a monumental amount of work. And it's an intensive process, even though they used, a machine learning and AI to try to fine tune the algorithms, it took a lot of work. So first they needed to establish that you can actually do this, develop a pipeline for how you might go through this process and, fine tune the protocol and all of those things. But it remains a big question, right? Because, what if these 4 particular patients were unique in a particular way and this doesn't apply to other people? My guess, and this is, again, I'm not at the forefront of I'm not doing this particular research myself, but my guess is that at some degree, patients, the individual signal might be different for not only each patient, but also the question at hand. If a patient is really fluctuating with their medications and you want the adaptive DBS to try to adapt to their medication cycle versus if they have sporadic symptoms that are brief and come on and go, and you want to be able to respond sort of on a faster time scale. So my guess is that, in the era of personalized medicine, one size will not fit for all. There will still be a role for, adaptive DBS based on the beta band. There might be a role for gamma signals, maybe in the future iterations of the devices that become commercially available, maybe we'll be able to integrate multiple signals. So the device that was used in the study, the RC+S, which is not clinically available, can actually allow input of 4 separate signals into the brain. And in a portion of the talk that I didn't talk about, they actually used 2 signals. They said, can we add the beta signal to the gamma signal and see if together they predict better? And in this particular case, they said no, adding the beta signal on top didn't seem to make it better. But maybe in future iterations of the device, we will get a setting where, you can get a variety of signals, because my guess is that, much like every patient with Parkinson's can be different, our brain signals are probably going to be different as well. And we might need much more sophisticated ways of adapting DBS to really serve all patients well.
Okay, thank you. Someone says a person local to Stanford was told that the wait for DBS is shorter at UCSF rather than at Stanford. They were also told that they can do programming closer to Stanford so they don't have to drive all the way to UCSF for all the programming. Does that sound right to you? Do you know?
I can't say that I know the timelines of like wait times. These things fluctuate. You got, so I can't tell you that that's always true. I'm not sure who they were told that by and when they were told that. But it is true that if you have it implanted in a place, it doesn't mean you're stuck programming it there forever. Patients get devices placed, implanted one place or the other. We have patients who got implanted here, but they're from Nevada, and so they move back to their home state, and they get clinicians in their home state programming the device. So the programming does not need to be coupled to where you got your DBS implanted. So yes, you can get it implanted one place and program it elsewhere. But what exactly the wait times are, I really can't tell you.
Okay, yeah, that seems reasonable. And also, I think it's important for people to know that general neurologists are often trained to do the programming, so it doesn't need to be a movement disorder center for the programming.
I
Though,
wouldn't say generally they are. Like, I wouldn't say most of them are, but there are certainly.
yeah,
I mean, you don't have
there
to be
are some.
disorders.
Yeah,
There are some general neurologists who can, but it's not a standard part of neurology training. So most neurologists are not going to know unless they have a particular area of interest or the other, or they had a patient that they needed to learn. Now, it's not rocket science. You don't have to spend 4 years learning it. You have to have, having that general neurology background can be really helpful because, in order to do the programming, you need to have a knowledge of brain anatomy and, the rest of it you can learn. But that neurological, like being able to assess patients neurologically and knowing the anatomy can be helpful. But that said, vast majority of programming does get done by movement disorder neurologists. Though there are general neurologists who are also have taken the time and have developed the expertise to do it.
yeah, there are a few for sure out there, and just as you said, they for whatever reason seem to have some special interest in Parkinson's disease.
Absolutely.
Yeah. Um, okay, I don't see any more questions on DBS, so I'll ask you this general question that came up. What causes Parkinson's disease? Well, that's kind of a hard question, sorry. But the supplemental question was, is it top down or gut up?
Great question, $1 million question. I will say that no one knows the exact answer. We do know that it is probably a interplay between genetic susceptibility, like how you were built, certain environmental exposures, things like pesticides or, a variety of chemicals that we probably don't even know about, and the aging process. We think each of those contribute because, well, aging undeniably, because the older you are, the higher the probability that you are going to develop Parkinson's. The connection from genetics bears out by the fact that some patients, about 10 to 15% of patients, have a first degree relative with Parkinson's, and certain, genetic mutations increase the risk of Parkinson's, though we don't think of Parkinson's disease as a genetic, like a simple genetic disorder. Many patients don't have a easily identifiable genetic mutation, but because of the fact that there is this higher risk with certain genetic mutations, we know that genetics does play a part into it. And then the environmental exposure, like, as I said, things like we know exposure to pesticides has had an impact to patients who have had exposure or had a higher risk. In reality, it's probably not a single disorder. It's probably a combination of different pathways that lead to what clinically looks like somewhat similar, though even I will tell you as a movement disorder neurologist that there's a huge variability in how patients with Parkinson's present. So it's probably like lumping a lot of patients all together into one bucket and calling them Parkinson's disease, but probably Parkinson's diseases. So, it's a complex question, and the brain and the entire nervous system is a hard thing to study. So it's not for lack of trying that we don't know exactly what causes Parkinson's. But, there's so much research going on, and with time, we're better understanding the molecular pathways and the physiological mechanisms that are getting implicated and, trying to untangle what causes it. And there was a second part to your question, which was
top down or gut up?
So this is also hard, oftentimes, a symptom or an observation comes into view and then everybody gets excited and thinks that it explains everything. And the more we learn, we're like, oh no, it's actually kind of complicated. So I think defining it as top down or bottom up or like gut up is pretty simplistic. I don't think it just starts one place and spread. I don't aspire to sort of the prion hypothesis, which is sort of you get, once you get a few abnormal, abnormal deposits of the synuclein, then you kind of just, propagate themselves in that way. It probably involves both the gut, the enteric nervous system, and the peripheral nervous system and the brain, right? This is nowadays we have ways of detecting the abnormal like synuclein protein, which is found in Parkinson's, from skin biopsy. So we know it gets deposited, even in skin tissue, in the nerves in the skin. So it is a widespread, even though we think of it as a brain disorder, it really is a like body-wide disorder. But exactly where it starts, I can't say that any of us really know the answer to that. My guess is that it kind of starts different places and there's some stochasticity variability in exactly where it starts first, but with time it will be clearer.
Okay, great. Well, that's a very helpful answer, I think. Because sometimes saying we don't know, and it could be multi-cause or multi-pathway, and that's often how things work out to be. So with that, we'll let you go to your 4 o'clock patient appointment. Thank you so much, Dr. Zahed. It was really interesting talk and appreciate all of your time today. And thanks everyone for participating.
Thank you so much for joining today. Hopefully this was helpful rather than just too complex. It's hard to do justice to subjects like this that are this complex, but hopefully you were able to get something out of it. And thanks for inviting me over today.
Thank you very much. Bye-bye.